Today, we are very excited to have Dr. Axel Masquelin from Brigham and Women's Hospital here to speak with us. Professor Masquelin did his PhD at the University of Vermont, and he is doing a postdoc at Brigham and Women's Hospital. Um, and he's here to speak about his work on applying AI to uh, cancer classification in chronic lung inflammation disease.
Again, thank you for the wonderful introduction and invitation to give this talk. Um, Hopefully, it'll be informative for everyone. I tried to keep it accessible to all levels while giving enough information for any technical experts to reproduce the results that we show today. Um, so the title of the talk is Leveraging Self-Supervised Learning and Co-Occurring Disease Imaging to Augment Lung Cancer Diagnostic. The co-occurring disease is what I would say is the most important part of this presentation, as we really are exploring how can we leverage alternative data sets in the space of lung cancer to augment what we have to train models. Before I dive into it too deeply, here's a quick conflict of interest. I am a co-founder, shareholder, and consultant for Predictive Incorporated. It focuses on AI sport telemetry, but none of the research here was funded by them nor related to the work of that company. For PhD students who are potentially on this talk and looking to transition, I always recommend, as a mentor, to look at the National Postdoctoral Association, a tool and resource that I didn't know existed. So for PhDs, I highly recommend looking at that. Then you also have LinkedIn for industry postdocs. And then if you're more on the math sides or other resources that I've used, also the American Mathematical Society, Insider, Higher Ed, and Nature Careers. But I'm happy, this is all to say that I'm happy to chat with anyone who has any questions on the transition process to postdoctoral fellowships. So for today's presentation, I'll start by giving you a small overview on smoking injuries, specifically related to smoking-related injuries, specifically related to non-small cell lung cancer, and then tie it in with COPD, so chronic obstructive pulmonary disease, and how leveraging smoking-related injuries that appear in smoking in chronic obstructive pulmonary diseases is beneficial for the task of actually detecting lung cancer in CT images. I'll give you a quick general overview of the methodology from the perspective of supervised learning versus self-supervised learning, just to give you a general idea of why supervised learning should be the strategy to go forward, especially as we're moving from having siloed data set to having a lot more open data sets that are available for everyone. And then tackle some key characteristics of the COPDGene data sets and how we leveraged it to become a more cancer data sets, the discussions, the results, and a quick discussion of those results, and then a conclusion of the future work to really round out the paper from PHI and hopefully in the next couple months move to publishing it into a larger journal. So lung cancer screening in the United States is primarily done on individuals that are considered at high risk. High risk individual is of the age 50 to 80 years old. They have about a 20 pack year smoking history. That means that they've smoked one cigarette pack per year, one cigarette pack per day per year for 20 years. Or you can smoke 4 cigarette packs per day for 5 years. But you've also quit smoking for less than 15 years. And by defining these individuals as being of high risk, and by changing the screening modality from just general CT modality to low dose computed tomography modality, the United States Preventive Service Task Force in 2021 showed that there's a reduction in mortality risk for those individuals by 20%. However, it's great we have a screening guideline just like mammography, so we should be able to reduce the incidence and the incidence of death related to lung cancer in the United States. However, there still remains a lot of challenges in deploying that. Nationally, as of 2023, the adherence rate of the low-dose computed tomography guidelines or screening guidelines for lung cancer was about a 6% national adherence, which is extremely low, with fluctuation between states depending on where you lived, if you were East Coast based or West Coast based, or if you lived in the central United States. As you can see from the map, if you live in New York, Boston area, you have a very easy access to those centers, those sites, those screening center of excellence, which is all the black dots. And then if you live in the central, such as Utah or Wyoming, you have a lot less accessibility to these screening centers that allow you to undergo the necessary yearly screening for lung cancer. Which means that when we look at it as capturing lung cancer as a disease and where we capture it in the individual, we typically capture it in the later stages when it has already metastasized, which means that these individuals that we do diagnose typically have a lower survival 5-year survival rate than if we were able to capture it in the earlier stages. So our whole premise of all the models that we're developing within the Applied Chest Imaging Lab here at Brigham is really to look at, can we increase a model's attention to early signs of smoking-related injuries that are associated with increased likelihood of nodule malignancy to better improve early detection of indeterminate nodules, which are defined as being 4 millimeters to 20 millimeters in diameter, to improve the quality of life of these individuals and improve the 5-year survival rate of patients that we are screening. Here's a very generic, so we can do this. We want to create these models, and typically we utilize supervised learning. And the best way to describe it, although I don't like the comparison, it's always the cat and versus dog. I think there's a lot more elegant, but just for generic overview, typically you need a data set that has both the imaging or CT image and then a label, whether the nodule is malignant or benign. And in this example's case, whether it is a cat or a dog, you utilize those image and then you predict the likelihood of it being a cat or a dog. And you do some form of backpropagation based on your loss, which is typically a binary cross entropy. All these are standard, but requires large labeled data sets to avoid overfitting. You learn features that are very specific to the task, meaning that you're not going to build a general model that can then be translated to 1, different sites, or 2, different disease types that are associated with pulmonary health in general. And oftentimes, we have a scarcity of annotated data sets. For example, the National Lung Screening Trial, which is one of the largest lung cancer data sets available, has about 25,000 individuals within the low-dose computed tomography branch. And of those individuals, only about 3.6% have some form of lung cancer. I believe it comes out to, in our specific case, about 360 malignant nodules in that. So we can train, obviously, we can do and train these data sets, or we can utilize these data sets to train models, as Seibel has demonstrated, or various other, the Google paper in 2019 that shows end-to-end lung cancer screening, that showed that you can train a neural network model to perform equal or better than board-certified radiologist. And depending on your endpoint, you can have different types of models that predict different likelihoods of malignancy, how you are going to be in 5 years, or if you require multiple scans, all of them have different workflows. So the workflow becomes kind of important in how we talk about the data sets and how those labels apply. But when you talk about self-supervised learning, the goal doesn't become to train a model for a specific necessary task. It's to generate an embedding that is generalizable to many downstream tasks of interest. So that can be segmentation, prognosis, classification, detection of nodules. All these things are kind of have a different labels that you need. And so you can build a general approach that says, I only have images of cats and dogs. I don't necessarily have a lot of label for them. So what I'm going to do is reconstruct the image as I encode them and then decode them to create an embedding that is robust and extracts wide degree of features to allow that reconstruction. So from an autoencoder perspective, what that looks like is you have a first stage pretext objective. So this might be a reconstruction, or if you know of contrastive learning, this might be some other contrastive learning methodology. And you would then provide an encoder the input image to then reconstruct your output image to some degree of some reconstruction strategy. This might be reconstructing the colors of the image. This might be adjusting the image from a rotation back to a normal phase of the image. Once you've trained this general model once you've trained this general encoder and have a generalized embedding in a sense, you can freeze the encoder and that embedding, and then train a downstream classifier to do whatever task you may be interested. So this might be the 1 to 6 year prognostic task of, is that patient likely to develop lung cancer, or is that nodule likely to become malignant in the next 6 years? Or from a single low dose computed tomography scan, this might be, is that nodule currently malignant or benign? So you can do this through a wide variety of methodology. As I've said, whether you do some form of reconstruction, tilting the image, some form of destruction of the image that the model has to reconstruct, or through contrastive learning. The path that we typically like to utilize in our lab is through reconstruction, specifically masking of the images, to allow the network to learn very specific features of very specific features associated with the disease. Many times when we consider from a clinical perspective, a location in one, or if you consider lung cancer from a clinical perspective, the location of the nodule will not necessarily be impacted, or the features associated with the nodule in the surrounding area will not be clinically impacted by some region very far away from the nodule. So if my nodule is within the left lung, I will not necessarily need to utilize the right lung as part of my training set to describe it. So I will only care about reconstructing that specific region or features associated with the remodeling process that happens as cancer develops. The masking autoencoders provide that. And there have been a few papers that provide really good examples of the strength of these methodology. The first and original paper was the masked autoencoder of scalable vision learners. Then there was papers from the drug discovery perspective where they looked at reconstructing cellular morphology to predict perturbation on cell health. And more recently, in the medical imaging space themselves, there was self-pretraining with masked autoencoder for the medical imaging classification and segmentation task on MRI imaging. So we took these papers as inspiration for our model and where we wanted to go in terms of the downstream tasks for what we were doing. Data is very important in terms of everything that we do. So here's a quick plug for the Imaging Data Commons sponsored by the National Cancer Institute. Dr. Andrew Fedorov here at Brigham and Dr. Ron Kikinis are the primary PIs on this specific project. But the Imaging Data Commons provides a repository of CT images or MRI images that anyone can gain access, download the information and the clinical CT, along with segmentation and other labels that have already been provided on them, and basically build and curate your own data set. So this is just a plug for open source data set, and you can contribute to the IDC or learn how to utilize that platform on the IDC website. So it's great that we have these open source data sets, and it's great that we can utilize self-supervised learning, but we still face a challenge to the notion of detecting cancer in that early stage that I showed at the very beginning, where we want to be able to capture increase the number of diagnoses that happen in the early or regional stages so that we can have a significant impact on the 5-year survival rate. And that is strong, that is impacted by the probability of capturing the disease and by the probability of capturing the disease in the earliest stage possible. So when we talk about the National Lung Screening Trial, which I had mentioned has the low-dose computed tomography branch and the X-ray branch. In this case, we're focusing specifically on the low-dose computed tomography branch. We have about 26,000 individual within that. Of those 26,000 individuals, we wanted to focus on single solid pulmonary nodules that fit an inclusion criteria of 4 millimeter to 20 millimeter in diameter, because any nodules greater than 20 millimeters in diameter typically have a 50% increase in likelihood of malignancy. So we want to stay in that early phase where there is kind of a lot of ambiguity about what the nodule state most likely is. And from a clinical workflow, if you have a nodule of greater than 20 millimeters in diameter, you're most likely going to be biopsied at the time of screening. Then we wanted to simplify the problem because we were doing multiple projects to not include nodules that were attached to the pleural space or pleural base. That's purely from being able to extract radiomic features, as one of the papers that I cited earlier was my own. And then we wanted them to be clearly defined in the parenchymal space. So this whole process resulted that we went from 26,000 CT images, or 26,000 individuals, to about 3,533 individuals within our final data set. Of those individuals, only 360, or I believe it's 364, were malignant nodules themselves. So that means we have 3,200 and so, so individuals that are benign nodules. So we have a very imbalanced data set. So what we end up facing is that we have, one, a skewed disease toward the late stage, two, biased in terms of the quality of the benign versus malignant, and then three, we didn't have as many sites as we wanted to be able to make a model that was not site specific. So we started thinking of what other disease data sets we could leverage. And the first disease data set that kind of popped up and that our lab is very used to using is COPDGene. It's a chronic obstructive pulmonary disease data set that has been well curated. And it has a lot of labels about the parenchymal health of the patient in terms of the gold standard and LA 950. So we have a lot of segmentation maps that characterize how healthy the parenchymal tissue is of that data set. What we didn't have is any nodule information. We, one, did not know that if any of these individuals had nodules, and two, if we do find nodules, we have no way of determining whether those are malignant or benign nodules. So we have no downstream labels. So we started with asking ourselves, well, can we even detect any nodules within the COPDGene cohort? We trained an NNUnet based on the medical segmentation decathlon, COVID-19, and LIDC IDRI to detect and segment nodules within the COPDGene cohort. What ended up resulting is that we were able to find a lot of nodules within these individuals and potentially a lot of false positive. And these false positives are most likely mucus plugs, abnormal vasculature, or what we've ended up seeing is abnormal vasculature and some form of more dense blood, vasculature. And so obviously we're capturing a lot of these false positives. But from our workflow perspective, we're not going to care that they're false positive because we don't need to train the label to discriminate whether that's a benign or malignant nodule at the COPDGene dataset stage. So we now have a dataset that is on 10,000 individuals that has captured multiple nodules per individuals And that also allow us to capture an important criteria, which is emphysema, or the degree of fibrosis or destruction, smoking-related injuries within the parenchymal space that is associated with worse prognosis for these individuals. Which by worse prognosis, I mean like increased likelihood of a nodule being malignant. The COPDGene data set, if we look at it, we ended up characterizing the 9,000 or so individuals within that had viable CTs. We found in 1,710 of them had no form of lesions. In many of these individuals, we had more than one lesion, so we decided to take the maximum nodule diameter. So we only focus, these characteristics are only for the largest nodules. It ignores any smaller incidental findings that may be just mucus plugs. And we end up finding that there's about 1,450 nodules of less than 6 millimeters and 6,000 or so that are greater than 6 millimeters. We used the 6 millimeter cutoff following the lung rats guidelines, where we're saying that nodule of technically greater than 8 millimeters, but in this case 6 millimeters, is higher likelihood of being malignant versus less than 6 millimeters. We may fall in the range of this could be a mucus plug. This could be any other form of benign lesions in a sense. Looking at the characteristics of these individuals, we end up finding that predominantly individuals with nodules present were older than individuals with no lesions, no nodules, which is similar to published literature. As you age, as you grow older, the likelihood of you developing lung cancer increases if you are a smoker. The pack years tended to be higher for individuals with larger nodules. And then the smoking status, we ended up capturing more smokers, heavier and more current smokers in the 6 millimeter and greater group. In terms of health, in terms of COPD gold status, so how much emphysema they have in their chest or how impacted their lung health is, we end up finding that we have a lot of gold stage 4 in the data set, and that it is also, but it is not significantly across. The only one that is significant is the gold stage 0 across the board. And then when we look at their clinical representation or the clinical status, in a sense, of their ability to walk, the distance that they're able to walk, the degree of emphysema present in those in the lungs, and the amount of gas trapping present in those CT images, we see that the larger nodules tended to have a higher score across the board than smaller nodules or not having any nodules, which confirms it confirms the basic assumption that individuals that smoke more, individuals that have worse lungs or higher likely are more fibrotic and emphysematic regions of their lungs tend to have are more likely prone to developing cancer. When we compare it to the COPDGene dataset, what that means is that of the 10,000 or so individuals that we had compared to the 3,533 individuals within the National Lung Screening Trial, we had a significant difference in the age group and the pack years. So we had a cohort that has a lower pack years compared to the National Lung Screening Trial. And then in addition, we actually detected a lot more nodules than the National Lung Screening Trial for us, because remember, the National Lung Screening Trial inclusion criteria was single solid pulmonary nodule. And yes, and so, but we have no labels for any of the nodules that we detected within COPDGene. The diameter of the nodules in COPDGene tended to be greater, slightly fell outside when we include all the nodules that we have. It falls outside of our inclusion criteria, but it has a large distribution in terms of the variance. So we're capturing a lot of different nodule type. And then they tended to be more round, where sphericity of a nodule is tended to be associated with a higher likelihood of it being benign. The one caveat that we had, and in any of the results that I'm presenting today, so you do have to take the results here with a little bit of a grain of salt, and we're hoping to have this fixed soon for the paper, is that because of the time crunch of submitting to PHI, we were not able to run across the 53,000 nodules that we had. So we balanced the data set to some extent and only grabbed 5,000 from the COPDGene data set to do a comparison as pre-training. And again, really important to highlight that there's no labels on whether the COPDGene data set is malignant or benign. So our workflow becomes for the masking autoencoder to really, one, destroy and corrupt the image. So remove, as we're using a vision transformer, remove sets of patches within that image so that the task of the model is to reconstruct those specific patches. And then move downstream to, once we've properly reconstructed the images, move towards a classifying objective where we freeze the VIT encoder and only train the classifier layer on the national lung screening trial. In terms of the VIT base 16, we tried to keep the parameters very similar to the baseline that you can get from Hugging Face, meaning that the embedding side stayed at 768. The encoder depth, I believe, is technically less deep than the standard encoder. I do have the baseline values later on. And then we had normal attention head and a smaller input patch because we were not using 224 by 224 regions, but 64 by 64 by 64 to really focus on a region that actually captured the alterations that the nodule is most like, the remodeling that is happening in the pulmonary space that is impacted by the nodule. One of the sub-aims that we were also interested in looking at was whether the reconstruction quality and downstream classification performance would be impacted if we forced the model to pay more attention to specific features. So if we were to do random masking, well, as you can see in the left two examples, versus masking only the tumor regions and allowing the network to only reconstruct the tumor region, or masking the parenchymal region and requiring the network to only reconstruct the parenchymal regions. This was done to really look at not necessarily the quality of the reconstruction of these images, but where the information may be present in these images. How much contribution does the parenchymal space provide towards classification versus the tumor space? And then keeping the random masking as a baseline for any comparison. For the most part, I will say that all the results are better on the random masking, and I'll dive into those details later, but for when exploring the data, I would really focus on the random masking over the tumor or parenchymal masking. So we create this model, and we want to test it and run it, but we also don't know all the parameters that may be impacting the quality of our reconstruction and the quality of the accuracy on the downstream class task. So we were interested in doing some ablation experiments on the pre-training of COPDGene dataset and then fine-tuning or linear probing performance on the national lung screening trial dataset. So all of these results are describing the accuracy of the national lung screening dataset. So how well the model predicted malignancy versus benign. And when we look on patch size, we see that because we have a smaller region of interest, these 64 by 64 at the place of the 224 by 224, we have to go down in size to allow the model to capture more fine-grained details. So a smaller patch size tended to perform better compared to the baseline patch size of 16. We found that having less encoder heads tended to lead to better performance on fine-tuning and linear probing compared to the standard VIT base 16. And we also saw that mean square error led to the best performance in terms of linear probing, but mean absolute error without normalization for the reconstruction task led to the best fine-tuning performance. And then in terms of encoder depth and decoder depth and the embedding size, what we ended up finding is that a shallower encoder and decoder, along with a narrow embedding layer, tended to improve the performance of the masking autoencoder for downstream classification task compared to having a larger, more scalable network in a sense. This does match some recent papers and work by labs and companies that recommends building shallower models. I think we've seen this result quite a few times in terms of CNNs, where if you're building a very specific model, CNN model, you tend to specialize it, or that is specialized for a single task. You tend to build very shallow models, and they work better. In medical imaging, there's a lot of shallow models that outperform larger, deeper models. And in terms of the embedding space, I think one of the key characteristics is that because we have such a small region of interest, 64 by 64 for these single CT slices, we tend to have an embedding that doesn't need to be as large compared to things like larger language model or vision language model, or even some smaller language model, SLMs. When we could look at the performance of the methodology in terms of random masking, parenchymal masking, and tumor masking, we end up seeing that COPD, pre-training on COPD tends to perform better than pre-training on NLST. So pre-training on a co-occurring disease data set that captures more disease characteristics, so clinical characteristics associated with likelihood of malignancy, compared to using the National Lung Screening Trial only as the self-pre-training, tends to perform better than the self-pre-training. When we look at COPD versus COPD in terms of parenchymal masking and random masking, we see that there's a slight drop in performance that is actually not significantly that is not significant when we test it and do bond-Ferroni correction. And that the parenchymal masking, surprisingly, does better than the tumor masking in terms of performance in comparison. Our gut feeling initially was that the parenchymal masking and tumor masking that the tumor masking was going to do better than the parenchymal masking, because the idea would be that features associated with the tumor themselves, the size of it, and size, shape, and various intensities of the nodule would play would have a significant contribution towards downstream classification compared to reconstructing the parenchymal space of the surroundings. And then the thing that we were also interested in was comparing it to pre-training on ImageNet, as a lot of models that we get from Hugging Face tend to be pre-trained on ImageNet to some extent, versus training from scratch. And we found that self-pre-training or using co-occurring disease to pre-train our model tended to perform better than ImageNet or training from scratch. Now, that's all to say that off-the-shelf ImageNet pre-trained models don't necessarily have good features to translate to clinical tasks. At least that matches some of the findings from papers like Transfusion, which I have later in the slides, but finds that ImageNet pre-training is not necessarily going to give you a significant boost in performance. But I have to also preface that technically, to use an off-the-shelf ImageNet model, we had to change the region of interest from being 64 by 64 to a 224 to 2024 input. We tested via upscaling, which led to even worse performance, and the performance that you're seeing now is on resizing grabbing more of the region of interest at the place of just simply upscaling the image. For the paper, we aim to do more better comparisons between ImageNet pre-training versus co-occurring disease dataset pre-training, because we don't think this is an adequate representation and is most likely an artifact of a lot of changes that we made to the VIT-based 16 architecture. So in conclusion, or really what to take away from this paper is really that masking autoencoder pre-training on datasets containing pre-malignant condition, or in the case that of MRI or any other disease models, leveraging datasets of co-occurring diseases or of organ types is beneficial towards downstream classification tasks because you're allowing the model to build a better understanding of what it's looking at through the reconstruction task. Then random masking ensures that the model learns robust clinical relevant features at the place of being forced to localize on one region, such as the tumor or the parenchyma, and that the current and one of the biggest limitation and drawbacks of our methodology is that because our NLST dataset or specific inclusion exclusion criteria focus on only solitary pulmonary nodules, we did not run this on ground glass nodule or any other or part solid nodules. And so this would our performance would most likely lower if we were to include those, but we don't expect it to decrease significantly based on the fact that we're actually including a wide variety of nodule types from the COPDGene dataset, such as mucus plugs and other abnormal findings that are benign. Future directions for this project include the route to publication, which is doing a lot more downstream performance analysis, specifically of subgroups. Do we have an age artifact that we're including by training on COPDGene because there's technically an age gap difference between the two data set? Or is there a bias toward having better performance on lower smoking pack years because of the difference in the NLST? So we're planning on doing a lot of more population analysis of our findings. And furthermore, we're hoping to translate this model from being just a single task-oriented model that is reconstruction to downstream classification to augmenting it more towards the foundation model perspective of looking at the organ as a whole, building an organ level embedding, and then going down to segmentation, detection, and classification tasks. And secondly, future challenges include the never smoker lung cancer group that is currently rising across the world. There seems to be a shift in the population that we're seeing that from being individuals that are developing lung cancer are changing from being high at-risk individuals that are smokers to the never smoker category. So whether this model can actually classify on the never smokers because they may not have the same clinical characteristics of COPD, emphysema, or fibrosis in their CT imaging, and how do we incorporate that so we can build a better world model? I would like to thank the Applied Chest Imaging Laboratory, my PI, Raul San Jose Estepar, along with George Washko, and then all the postdocs, instructors, and other PIs that have provided a lot of mentorship and guidance on how to best formulate the idea and run the experiments and do controls, specifically from the perspective of the comparing to ImageNet. Any questions?
Thank you very much, Dr. Masquelin. That's a great talk. Do we have any questions from the audience?